Hello, let's talk about renal tumors. There are three benign renal tumors in this SDL. They're all pretty characteristic. Then we have an adult tumor and a kid tumor. So it shouldn't be hard at all to make this diagnosis in a test. Renal cell carcinoma, adults in the 50 to 70 range get it most often, and the number one risk factor is smoking. Wilms tumor, also the nephroblastoma is what it's called, develops because there are some residual stem cells left in the kidney that just refuse to differentiate. And so they continue to proliferate because most differentiated cells cannot divide. So those stem cells form the bulk of the Wilms tumor, and it's a pediatric tumor usually that'll present as a unilateral or bilateral renal mass that can get pretty dang big, and they might have an associated hypertension or hematuria. Let's get into these benign renal tumors. First, we have the papillary adenoma. You know that an adenoma is a glandular tumor. This is a benign cancer. You know that it's pretty cool because it's not an adenocarcinoma, which would mean it had malignant potential. But because this is just an adenoma, you know it's benign. These are pretty common. We find them on autopsies. We find them, we catch them on CTs. There's a wide age range. There's no preferentially affected population. And so if you find this in a live person, you're going to want to look at it under a microscope. And what you'll see is a papillary architecture inside this mass. And it's filled with glandular cells, cuboidal cells with a very low degree of atypia. So that means they're well differentiated, which means they look pretty good, pretty normal. The papillary adenoma is associated with trisomy 7 and 17. And these things are, while not malignant themselves, they do carry some potential to evolve into a papillary renal cell carcinoma, which the carcinoma lets us know that's a malignant cancer. I want to pull up a quick image of, this is what in the upper left quadrant, this is what we refer to when we say papillary architecture. That means it essentially looks like a sea anemone or a starburst sort of shape. So papillary, frond-like, finger-like projections. And then when you slice the tissue, you get a slice that's got a bunch of ducts in it, showing you the tube work of those glands. That's a papillary tumor. What is an angiomyolipoma? It's exactly what it sounds like. It's got a little bit of blood vessel, a little bit of muscle, the myo, and then it's got some fat in there. So this is a three-component tumor. It's the most frequent benign renal tumor, and it's associated with tuberous sclerosis, which has two flavors to it, TSC1 and TSC2, which code for hamartin and tuberin respectively. And you will always remember that TSC2 codes for tuberin, pretty easy there. What happens whenever you have a mutated TSC1 or 2 gene is that these genes suppress mTOR signaling. And if you just have uncontrolled mTOR signaling, your cell's going to grow, and divide. The mTOR pathway is a growth pathway that will activate the expression of growth factor receptors, and it'll localize them to the outside of the cell, and it'll allow the cell to get through the G1 phase quicker and quicker. On histology, you slice this thing open. What do you see? You see fat, you see blood vessels, you see smooth muscle. That makes sense. It's an angiomyolipoma. And the big risk of these tumors is hemorrhage because of that angio blood vessel component. It can get pretty out of hand, especially if it gets into the retroperitoneal space, because that's often it'll develop before patient knows, because they're not exactly looking at their back, you know. Let's look at some pictures. Here's a papillary adenoma. Low-grade cells, well differentiated, with a scant basophilic cytoplasm. This is not a large mass right here. And if you zoom in even further, you see that the cells there's no nuclear atypia really. You don't see any mitotic figures in this. Yeah, they're a little bit hyperchromatic, but that's the case for just about any neoplasm. Again, trisomy 7 and 17 association for that papillary adenoma. Here's the first aid slide for tuberous sclerosis. We've got a good mnemonic to remember all the presentations. It's hamartomas. And indeed, you do see hamartomas in the setting of tuberous sclerosis. What you are also going to see is subependymal giant cell astrocytomas. That's the SEGA. That's a glial cell tumor, remember? And you're also going to see angiomyolipomas in the kidneys. That's the primary tumor for this SDL. And skin tumors, skin nodules. Hamartomas are essentially just little spots of distorted architecture that aren't cancerous by themselves, but they are tough and sessile and fibrous in nature. Here's a picture of a hemorrhaged angiomyolipoma that's bust open. Look at how big the capsule around that kidney's getting. I'm assuming that all the blood here has stayed within the renal capsule. And look how swollen it is. That's on the right side of the body. Patient presented with a chief symptom of hematuria, but then they looked and the patient was anemic and in acute kidney injury. So if you are in AKI, you would probably see a lab panel that's got a high BUN and a high serum creatinine. Those are our two chief markers right there. So if your patient is confirmed for tuberous sclerosis, you know that they are in danger of these angiomyolipomas. Here's what it looks like under a scope. A lot of blood, many engorged vessels here, surrounded by a little bit more fibrous tissue than normal. And we see a lot of fat there in the middle of this kidney parenchyma, and a smooth muscle component too. Off to the right side of this page, spindle cells that have tips at their ends. They're shaped kind of like cigars, or like you twirl them up, Chinese finger traps maybe. So that's an angiomyolipoma. Here's another look at it. There are the spindle cells. And it'll have a storiform or a kind of Van Gogh starry night appearance. Any spindle cell tumor does take on that starry night appearance. So here's an oncocytoma. This is where we're going next. And in this image, the cancer's on the right side of the page. Really, as you get over here, that's where the oncocytoma is. These are pink cells, very pink cells with normal nuclei. It's a low-grade tumor. It's benign. And oncocytomas pop up out of the intercalated cells of the collecting duct tubular epithelium. Now, what do those cells do? So you've got a normal, just straight up epithelial cell in your collecting duct, but then you've also got these alpha intercalated cells. And what makes them unique is that they have proton pumps on their surface. And so they contribute to modulating the acidity of the urine. And these cells do not have the NAK-ATPase on them that's going to, or the ENaC rather, I should say, that's going to reabsorb sodium from the lumen of the collecting duct. Again, instead they're transporting protons. Those are alpha intercalated cells. And they're upregulated. Their activity is upregulated by the presence of aldosterone, just like most other cells, any other cell in the collecting duct region. Here's what it looks like grossly. A central stellate scar similar to a tumor that we've already seen in the liver. You only see this in about 30% of cases, but as far as kidney tumors go, it's fairly pathognomonic. Here's another look at it. You've got these granular, large eosinophilic cells with nuclei that aren't dividing. You know, there's no messed up mitotic spindles. They're just big and they're dark. One more look at it, same thing. It's pretty in pink, so you know it's not a clear cell tumor. That's about it. Oncocytomas are benign, abundant granular eosinophilic cytoplasm. That's how they would say it in words. And patients get it. Elderly patients get it. They tend to not present with any symptoms. So renal cell carcinoma, big bag cancer. Adults get it. Diagnosed between 50 and 70 years typically. Not the most common tumor. Well, right off the bat, something important about it is that there is a very high metastatic risk to the lungs and to the bones. Kidney tumors do like to metastasize. So they do that by encroaching up the renal vein and then into the IVC. And then once they're coating the interior lining of the IVC, it just takes a big wave of blood to push some tumor cells off and get them into the right side of the heart. But then after that, the lungs. And maybe if they go into the azygous vein instead of going up to the right side of the heart, because the azygous connects to the IVC, maybe they can get into the spinal column that way too. And so that would be a very bad metastasis there as well. Smoking is the #1 risk factor. I wish that's all that this section said. I wish it just said smoking is the #1 risk factor and left it at that, you know. But if the patient's not a smoker, my money is on occupational exposure because there's quite a few of those. You have some syndromic renal cell carcinomas. So you can get it de novo, kind of wild type, not necessarily have any genetic predisposition to it, or you can have that familial predisposition to developing renal cell carcinoma. So that's probably the subject of a test question because there are a handful of them. First, there's von Hippel-Lindau disease, which is going to give you a clear cell renal carcinoma, and it's associated with other cancers. And so that's also a potential question. Patient's got this cancer, patient's got this gene mutation. What other cancer do they probably have? So if it's VHL, that means they probably have a hemangioblastoma somewhere in their brain, possibly growing in their eye, or they might be positive for a pheochromocytoma, which is an adrenal tumor, which would sit right above the kidneys. So who gets von Hippel-Lindau disease? Who presents with von Hippel-Lindau disease? This is important because some of these syndromes are really pediatric, but von Hippel-Lindau is a young adult syndrome. Patients have mean ages in their 20s and early 30s for presentation. What's the gene? The VHL gene. It's a tumor suppressor gene, which is responsible for degrading hypoxia-induced factor 1. So let's break that down. Hypoxia-induced factor. Whenever there is ischemia of a tissue, that tissue is normally going to make hypoxia-induced factor. And that's what creates the stress growth response to ischemia. And if you think about it, when you go for a run, you know, running all the time, get your heart in great health. And going and exercising all the time, moving your muscles about, get your skeletal muscles in great health. And it's like, why? Why would working them get them in good health? And it's because of this HIF1 protein that is going to induce angiogenesis in response to ischemia. So that's the premise. You stress your cells, HIF1 comes in, HIF1 makes new blood vessels and delivers even more nutrients to those stressed cells. And so they'll hypertrophy, or maybe depending on the organ, they'll undergo hyperplasia in response to the stress. So HIF1's critical in that adaptive growth pathway. Now, imagine you've just got HIF going all the time. It's not even coupled to hypoxia anymore. You could have a totally great perfusion of this tissue and you'd still have a lot of HIF. What would happen to that tissue? It'd grow up, you know, it'd get really, really big and swollen. So cancers love this protein because what that means is that they've got access to the vasculature and circulation. So they will get all the growth factors that they need, and they will be even more enabled to metastasize elsewhere with that greater vasculature. Summary sentence, inappropriate HIF1 alpha stimulates angiogenesis. Again, tumors are all about that. Then we've got hereditary leiomyomatosis and renal cell cancer. Tells you all you need to know. Just remember the gene's FH. It's a tumor suppressor gene, and these patients are going to have benign smooth muscle tumors. Hereditary papillary renal cell carcinoma. You got the MET proto-oncogene. You see a papillary renal cell carcinoma. The most common gene involved is that MET gene. It's going to be a gain of function gene because it's a tyrosine kinase, which is a growth factor receptor, and it's also autosomal dominant. In fact, I think, yeah, all these dudes are autosomal dominant. Birt-Hogg-Dubé syndrome, all BHD. It's autosomal dominant. It's involving a tumor suppressor gene, FLC1. Don't need to know what that does. You need to know to look out for angiofibromas, which is going to be a superficial type of vascular tumor. You might get one on the skin, like forearm, cheek, something like that. And then also lung cysts and secondary spontaneous pneumothoraces. So, you know, that's going to be air getting into the lungs, and it might cause atelectasis, which is a collapsed lung, and you know that you're going to have to check for a tension pneumothorax there because that would be very, very bad. So yeah, you remember all this stuff. Now we talk about the WHO classification of these different renal tumors. So this section goes into a little bit of detail about every single subtype. Really, the ones that you want to know are clear cell, papillary, chromophobe, and the rest are pretty self-explanatory. So clear cell, the cells are clear. They pop up in the proximal convoluted tubule. And that's opposed to papillary renal cell carcinomas, which pop up out of the epithelium lining the distal convoluted tubule. And then chromophobe renal cell carcinoma arises from the epithelium of the collecting duct. intercalated cells that like to pump protons. So you've got 3 different cell types giving rise to 3 different variants of renal cell carcinoma. And then if you count the kid tumor, Wilms tumor, then you throw stem cells in there, and that looks like answer choices A through D to me. So with the clear cell renal carcinoma, the vast majority are caused by biallelic loss of von Hippel-Lindau gene. You need to lose both copies, makes total sense. It's a tumor suppressor gene. But if that VHL gene is not involved, the second most common gene involved is PBRM1. And you need to remember that because clear cell renal cell carcinoma is so prevalent to where every medical student knows von Hippel-Lindau gene. Okay, duh, check. So boards might ask you for the second most common in these more prevalent, more predominant pathologies that you'll see out there. Most of them are sporadic. Papillary renal cell carcinoma, this is the one that's got the frond-like, finger-like sea anemone projections. What you see in this one is a trisomy 7, maybe a trisomy 17, maybe a loss of the Y chromosome in these cells. And it's going to have the MET gene mutated if it's familial. Again, it arises from epithelium of the distal convoluted tubules. Chromophobe renal cell carcinoma. Chromophobe, what's that mean? Scared of color. So this cancer is somewhere in between a normal cancer and a clear cell cancer. Because in a clear cell cancer, you know, it's white like how this PDF page is white. But a chromophobe, it's not going to be totally clear. It's just going to be a very pale granular pink. So you'll see what I'm talking about in a minute. The gene you need to remember for this one is FLC1. The XB11 translocation carcinoma is related to the TFE3 gene. These patients are going to present usually in childhood or as a teenager, early 20s, because the pathogenesis of this, kid has a tumor, kid gets treated with cytotoxic chemotherapy, and the chemotherapy is going to influence translocation involving the TFE3 gene every single time. And so the kid presents 5, 10, 15 years later with metastasis because this tumor pops back up. And I believe that they would give you the translocation, ask you the gene, or give you the gene, ask you the translocation. I don't think there's much else to ask about the XB11 translocation carcinoma. Collecting duct carcinoma, less than 1% of all renal cell carcinomas, they would probably tell you this thing's in the medulla, this thing's from the collecting duct, and then you just say, okay, loss of chromosome 1, 8, 9, or 16. Not much to that. And then renal medullary carcinoma has got a sickle cell trait association. Patients are almost always black, and it's got a SMA-RCB1 gene mutation. So those last two are so rare to where I don't feel like they want to ask you that on this exam. Let's look at the pathology of these things. So clear cell carcinoma of the kidney. Remember we said VHL gene 80% of the time, and it likes to grow up out of the proximal convoluted tubule. It's going to have a yellow color because the tumor's just swollen with lipids, fats, and those fats wash out whenever you stain the tumor. And so that's why it's got this clear appearance, kind of like how adipocytes look clear on a histology slide. So these tumors do like to invade the renal vein and grow into the IVC, and there's your metastatic risk. What do you see when you look at it? Apparently empty cytoplasm. That's why it's called clear cell carcinoma, due to high content of lipid. So anytime a cell's got lipids in it, it's going to wash out. Same for glycogen too, except you can see glycogen with a special stain. Remember, that's our periodic acid shift. So that's all that you really got to know about the clear cell carcinoma, other than what does it look like? Here's some info about von Hippel-Lindau. It got a nice mnemonic for it, HARP, H-A-R-P. You can remember that because it starts with an H, just like Hippel starts with an H. And you're also going to see something else that starts with an H, hemangioblastomas. You can get them in the brain, you can get them in the eye, you can get them in the cerebellum. Here's one in the spine. Very, very bad tumor, affects a lot of bad spots. You can see some cavernous hemangiomas. Remember, those are just going to be tortuously dilated venous spaces with a thin single layer endothelial lining. And VHL does like to give you bilateral renal cells or pheochromocytomas. Here's a bilateral renal cell carcinoma. You see a big globule here, then you see another one on the left. That's 2 tumors. Here on the right side of this page is a bilateral bilateral RCC plus a bilateral pheo. And here is the pheochromocytoma. I'll put this in yellow. Remember, your adrenals are pyramidal in shape and sit atop the kidneys. And so if our kidneys, you can tell this is kind of the kidney right here, and that thing sticking out of it like a boil. I'm thinking about that kid from the Fairly Odd Parents. That thing sticking out of it is our renal cell carcinoma, but circled in yellow is the pheochromocytoma. And then here's your kidney on the other side, and it's a little bit more messed up over there. There's a cancer in the middle, it's looking like, and then again, pheochromocytoma sitting on top of the kidney. So that's von Hippel-Lindau that can give you that. Here's another example of a bilateral pheochromocytoma. I'll outline the kidneys in green. These are normal kidneys, it seems to me. They've got their normal shape. Neither one is too shrunken or atrophied. However, you do see, again, this bilateral pheo, which has got a total golf ball size and shape to it, and this is going to be in a kid. Here's your clear renal cell carcinoma. It is on the right side of this page. Everything to the right of that blue margin is your clear cells. They're containing lipids that are washed out. VHL gene number 1, PBRM number 2, proximal tubular epithelium. Here's another look. Those cells look pretty crystal clear to me, yo. You can see straight on through to the other side. Now we talk about papillary renal cell carcinoma. What does it look like under a microscope? Well, you see foam histiocytes, foam macrophages, lipid-laden foam cells. Same thing you would see in the tunica intima of large arteries in the setting of atherosclerosis. So, not only that, you might see some psammoma bodies occasionally, which are going to be very, very pink, very eosinophilic, looking like squamous keratin pearls almost. Here's a papillary renal cell carcinoma, papillary, anemone-like, frond-like, finger-like projections, and sure enough, you cut through it and you see many tubules. You've got macrophages inside the lumen of the distal convoluted tubules of this kidney here, and papillary carcinomas, again, like to pop up out of that DCT epithelium. So here's another look. Foam cells inside the lumen of these tubules. And although the foam cells are pretty clear, they are not, the whole thing is not clear. This is not a clear renal cell carcinoma. You should tell the difference here. A lot of preserved tubular architecture in this papillary tumor. Here's another example. This one hasn't got too out of hand yet. But of course, remember, these macrophages are not the cancerous cells. The cancerous cells are these purple ductal epithelial cells lining the DCT. So again, what are our mutations? What's the genetics for the papillary carcinoma? Trisomy 7 and 17. If it's familial, that MET gene gets involved. Chromophobe renal cell carcinoma. Pale eosinophilic cells with solid, slightly granular eosinophilic cytoplasm, and they're arranged in sheets. That means they're all on the same plane like a sheet of paper. What's the gene FLCN? Where do you get these? Collecting duct. Let's take a look. So these are pale, but they're not quite clear. A couple of these cells are pretty clear, but not the whole dang thing, yo, not the whole thing. This is a better picture. This is really showing you how the typical chromophobe would look, how they will show you a chromophobe on a test. It'll have this soft baby pink cytoplasm to it, but it won't be totally clear. So it's somewhere in between the clear cell and the dark epithelial, epithelial cells of the papillary cancer. The XP11 translocation, again, I predict they'll give you the gene or the translocation and then ask you for the other one, if they even want to ask you about this at all, because it's not a hard question. Nothing histologically really sets this apart from any other cancer to make it worthy of being diagnosed based off visuals alone. They won't ask you to do that. Collecting duct carcinoma, where do you get this? I wonder. Loss of chromosome 1, 8, 9, or 16. This is a bad cancer. This is virtually always high-grade presentation. So you'll see dysplastic nuclei, high degree of atypia, You would probably see many mitotic spindles and a high degree of proliferation as well, and it would be dedifferentiated. And this tumor has an infiltrative growth pattern. I could see that getting worked into a question stem as a clue, because it's a nice, easy way to tell you that this thing means business. Do I have a photo of a collecting duct carcinoma? I do. High degree of atypia. There's a big swollen nucleus down there. Here are some cells down at the lower edge of this that are really not shaped like cells. They're shaped like fangs or like leaves or something, but they're lacking an ovoid shape to them. And then there's a lot of desmoplastic stroma in the midst of this, which you would never see in a normal kidney. So you know that you're looking at some sort of tumor. Here's the first aid for renal cell carcinoma. Man, look at how big this thing can get. So here's your kidney. There's your kidney. In blue, man, there's your cancer. Over here on this axial CT, lower right, we've got right kidney, left kidney with the mass inside the left kidney. And then up here, we've got the right lobe of the liver. And it looks like we got the spleen sitting over there. And then maybe some descending colon after that splenic flexure right through there. And then what are these muscles right here? That's going to be your psoas major muscles. They're attached to the lumbar spine. And then your iliac fossa down here. There's your bladder. Correct. So you know all that. Who gets renal cell carcinoma? Old people, not kids. Kids get Wilms tumor. What's the risk factor? Smoking. Paraneoplastic syndromes. I think that is right about to come up. So let's go find that here. Hypercalcemia. What gives you hypercalcemia? Too much parathormone-related protein, PTH-RP, which is going to functionally accomplish the same objective that PTH wants to. So you release PTH anytime your blood calcium dips low. And the effects of PTH are as follows. It's going to induce absorption of calcium by gut endothelial cells, epithelial. And then number two, it's going to unlock calcium from your bones by stimulating osteoclast activity. And I think that in the kidneys, it's going to work on vitamin D to get some hydroxylation going so you can make 125 active vitamin D, which I think that's our cholecalciferol, isn't it? So the kidneys are what activate vitamin D. The liver modifies it a little bit, but the kidneys really get it going. And so you need vitamin D to play with calcium levels and to really get calcium into your body. So that's what PTH does. If the tumor's making PTH-RP, which is the same as PTH, you're going to have too much calcium in the blood. Erythrocytosis, due to the production of EPO, the kidneys are what normally make EPO. So any renal tumor, maybe it retains the ability to synthesize EPO, and maybe it makes way too much of it. So how does this manifest? A high red blood count and thick blood. You might see, so are these patients going to clot or bleed? They're going to clot because their blood's going to be more viscous, and thus it's going to move slower, and thus the heart's got to pump a little bit harder to push the same amount of blood because it's more cellular. So is your hematocrit up or down? It's down because the hematocrit, no, I'm sorry, it's up, it's up. Ah, Lord, now I'm all messed up. Hematocrit, is that the cellular or the non-cellular part? I hate feeling like a dumbass, but par for the course, right? It's a measurement of how much someone's blood is made up of red blood cells. So hematocrit goes up. So the cellular part of blood goes up, and these patients like to clot. Now, if blood were less viscous, if you had an anemia, you'd be more prone to bleed because your heart would be pumping blood, and, you know, it'd be like going to the gym and like doing curls with like 5-pound dumbbells, you know, you'd be throwing them up like that. And so whenever that fast moving blood hit a turbulent spot, it would damage the endothelium a little bit more at those spots of turbulence than slower, thicker blood would. Arterial hypertension is a paraneoplastic syndrome. How do you get that? Renin. So kidneys make renin. Maybe a kidney tumor makes renin. And you could have upregulated renin, maybe if the tumor's growing in a manner that compresses the renal artery as well. That wouldn't necessarily be a paraneoplastic syndrome, but it would have the same effect. And last one, non-metastatic hepatic dysfunction, because the tumor makes a lot of interleukin-6, which activates the production by the liver of acute phase reactants. And so you see this cholestatic enzyme pattern, high serum ALP, high serum GGT, but liver enzymes are normal, and so is plasma bilirubin. So you say, patient doesn't have jaundice whatsoever, but they have the symptoms of obstruction. What's going on here, you know? IL-6. Metastatic spreading, lungs and bones. So that's renal cell carcinoma. That's our adult tumor. Wilms tumor is a kid's tumor. It's got a lot of synonyms, nephroblastoma chiefly. It's derived from the metanephric blastema. Remember that when your kidneys are growing, you kind of got two sides that meet in the middle. You've got your metanephric blastema, which is where all your nephrons come from, but then you've also got your ureteral bud, which is going to form the pelvis of the kidneys, and it's going to grow up and invest and kind of connect and attach to different metanephric blastemas. And so the blastemas will fuse and grow and form, again, your functional parenchymal kidney with all the nephrons and glomeruli and tubules. So Wilms tumor is thought to occur whenever that metanephric blastema that makes nephrons fails to grow up and get out of the house and go get a job and choose something they want to be. And it fails to differentiate, but it continues to just proliferate, grow, because that's all that stem cells do. So because they keep growing, these are going to be small blue cell tumors, just like any other primitive stem cell tumor. Classic example, Ewing sarcoma, medulloblastoma. Nephrogenic rests. Anytime you see the word rest, it's referring to a spot where there's a lot of cell division. And we saw like epithelial rests in the oral cavity. And the first time we saw that, I was like, what in the world is this? And why can't they call it something a little bit more intuitive? But now you know what it is. It would be one of these black or gray spots on this diagram. It can be either nephrogenic, these black spots, or intralobar within the lobe of the kidney. If it's this gray spot, and you just need to know that that's where the stem cells sit and just continue to divide. Persistent embryonic remnant tissue. Easy if they ask you that. Easy. The syndromes. Might want to ask you about a Wilms tumor syndrome. Three big ones. There's WAGR, there's Dennis Drash, and Beckwith-Wiedemann. So we've seen Beckwith-Wiedemann. Let's start with that. That's an insulin growth factor 2 problem. And IGF-2, I think, used to be called Wilms tumor too, because Beckwith-Wiedemann is always associated with WT2 whenever I look in first aid. So I'm going to consider that they're the same thing for now. Wilms tumor and hepatoblastoma, both of them. You can get both of them if you have this Beckwith-Wiedemann syndrome. How does it present? Hemihypertrophy. So maybe like one arm is like a lot bigger than the other, like Quagmire in that one Family Guy episode. Maybe they've got macroglossia. Maybe they've got hyperinsulinism. And indeed, this is associated with a macrosomia. Gestational maternal diabetes is associated with Beckwith-Wiedemann. And the baby will come out of mom, and the baby will just be big, massive. And it's because baby's had all this blood sugar being pumped into it, but then baby gets out of mom, and baby's got too much insulin. And so baby's going to go hypoglycemic in the hospital. So this could be a cause why. It's due to an imprinted gene, insulin-like growth factor 2. And so anytime you see imprinting, the next thing you should think of, just like Pavlov's dog, should be uniparental disomy, because that's how you get problems with imprinted genes. And when a gene is imprinted, that means that mom's got one copy of this gene and dad's also got one copy of this gene. But depending on the gene, maybe mom's copy is just going to get turned off in every single cell. So every cell in the body is going to have dad's copy and only dad's copy of that one imprinted gene. Well, this is a problem in the setting of uniparental disomy, which would mean that dad just didn't contribute his copy of the gene. So whenever the DNA says, okay, we're going to methylate mom's copy, you know, just like we always do, because this is an imprinted gene and mom's copy always gets methylated. Well, then you look over and it's like, well, time for dad's gene to start making the protein. And it's like, I never had dad's gene. You know, it's like, come on. So that's uniparental disomy. That's what's going on in this IGF-2 Beckwith-Wiedemann syndrome on chromosome 11. Now let's talk about WAGR and Dennis-Drash. So similar thing going on here. They both involve Wilms Tumor 1 is the gene. And in WAGR, you just straight don't have the gene. You do not have the gene. And in Dennis-Drash, you've got partial functioning of the gene. It's a point mutation. And so it's going to go a little bit downhill. But if you were to, you know, do a PCR on a cell, you would still find the WT1 gene product in that cell for Dennis-Drash syndrome. Not going to happen in WAGR. So WAGR sounds like a nice radio station. Actually sounds like a terrible radio station. It's an acronym, stands for Wilms Tumor, Aniridia, GU abnormalities, and mental retardation. So what is this, yo? Aniridia. This is what I remember Dr. Cashman saying way back in block 2. If you see a kid and you see a photo of the kid and they've got one red eye, you need to work that kid up for a tumor ASAP. So this is what he was getting at here. Aniridia associated with a lot of renal tumors in kids. You don't have an iris, basically. So that means that like the black dot that should be in the middle of the eye, you're not going to have that. So if you want to see more pictures, Google this. It's really cool. But I want you to know exactly. If you see this on USMLE or Comlex, you're just like, kid's got a kidney tumor. Just like that, you know, immediately. And it's probably having to do with chromosome 11 too. So back to the syndromes. That's WAGR. Dennis-Drash, partial functionality. You do see some GU abnormalities. You see some gonadal dysgenesis. But the real big symptom of Dennis-Drash is that the patient affected with Dennis-Drash is going to go into nephrotic syndrome very, very, very early on. In fact, it's an infantile nephrotic syndrome. And that is not something that WAGR has within its spectrum. Gonadal dysgenesis, male pseudohermaphroditism is what that can present as. So they'll just straight up have fused genitals. I guess that's something else that's not particularly in WAGR. So the genes, you read about the genes yourself. The most common one is this IGF-2 that's found in 69%. They couldn't round it up in Wilms tumors. It can be bilateral in a minority of cases. What do you see when you cut it open? You look at it under a microscope, you see small blue cells, which are mitotically active and packaged in sheets, arranged in a loose fibromyxoid stroma. And they might even be anaplastic, which means they're going to have large, dark, dense nuclei in cytoplasm. So what's the clinical presentation? It's a kid tumor. It's not renal cell carcinoma. You know that. Like, you know that for a fact. Kids present with hematuria, maybe hypertension, usually a big swollen flank region, just right around that rib 11 and 12. Big metastasis risk, yes, but good news is if it presents early, if we can catch it in childhood, at least we can treat it early, you know? So there is some good news at the end of that. Gross Wilms tumor. Nothing to write home about, just obviously a kidney tumor. There's your pelvis and ureter down there on the lower left. Here's a good schematic. Again, the loose fibroconnective stroma is a component of the tumor, but the cancerous cell is that stem cell, the small round blue cell that just won't figure out what it wants to be in life. Here's an example. Small round blue cells. Okay, purple. Fine. We'll compromise. Purple's close to blue, you know, pretty close. And here you are even more zoomed in. Here's some normal tubules there. There's your fibroconnective stroma. And then all the rest of this is your sheets of round primitive stem cells. Remember, IGF-1 is the most common, but that Wilms tumor 1 protein also likes to get involved too. How are we going to know if it's IGF-1? Well, the baby's going to be making a lot of insulin, and so they're going to be big because they're making insulin, and they can feed their muscles with all the glucose that they're pushing into it. So that's renal tumors.